Okay. Hi, thank you for joining us on our webinar today on fertility over 40. I'm here with Dr. Mark Surrey and myself.
Hi, everybody.
Maxwell. Next slide. So Dr. Surrey is one of the co-founders of SCRC and the medical director. He's been a leader in the field of fertility and reproductive medicine, including reproductive surgery and IVF. He serves as a clinical professor in the Department of Obstetrics and Gynecology at UCLA and holds a bachelor's degree from the University of Pittsburgh and an MD from George Washington University. He did his internship and residency at UCLA Medical Center. And he, as I said, is the founder of the practice. Next slide.
So Dr. Maxwell is a respected leader in reproductive medicine, and we stole her from New York. She was NYU and at another program in New York. And she decided that she liked the weather in California better, and we liked her a lot. So we managed to pry her away from New York and to our essentially to our Santa Barbara location, where she is running the clinical experience there. She completed her residency and fellowship at New York University and has had extensive training and experience with top fertility programs in New York City prior to moving to Santa Barbara and joining SCRC. So we're thrilled to have her with us. She's going to start off our little program today by talking a little bit about who we are and what we do. So we have some of the premier technology involved with fertility treatments in our locations in Beverly Hills, Santa Barbara, and Pasadena. And we're pleased to be able to share some information with you today. Susan?
Okay, next slide. Yeah, so as Dr. Surrey mentioned, one thing that sets us apart at SCRC is we have two premier laboratories, one in Beverly Hills and one in Santa Barbara. And what sets our labs apart is we have very experienced embryologists. We perform double witnessing and verification procedures to be sure that the correct people's gametes are being used. We perform vitrification on eggs, embryos, as well as sperm. And this is a flash freezing method that has really the best results when it comes to thawing. And we do a lot of embryo biopsy to check for genetic mutations. So we can check all 24 chromosomes and do screening. We can do sex selection, and we can look for single gene disorders such as cystic fibrosis or breast cancer gene mutations. We have the embryoscope at both laboratories, which allows us to take pictures of the embryos as they are developing so that we know which embryos are the best in terms of their development for transfer. And we have certified laboratory directors who are leaders in the field, and we are fully certified. Next slide, please. At SCRC, we offer a full service of fertility services, including egg freezing, sperm freezing, embryo creation and freezing, which includes in vitro fertilization. We do lots of different genetic tests. We can do gestational carrier and surrogacy, and we have a third-party program that manages egg donor cycles as well as sperm donors. Next cycle. Today, we're going to discuss age-related fertility factors and how to optimize your fertility. And then we'll discuss the testing that goes on when you become a new patient at SCRC and the treatment options available. And then we'll end with a Q&A if you have any questions. Next slide. So infertility is defined in patients who are under 35 years old if you've been trying to conceive for at least a year. And if you're over 35 years old, if you've been trying to conceive for 6 months. And the reason for this is the chance of conception per month goes down as women get older. Next slide. And as you can see here in this slide, the chance of conception when a woman is 30 years old is about 20% chance per month. However, it declines steadily in the 30s. So by 35 years old, the chance of conception drops to about 10 to 15% per month. And by 40, it can drop to about 5% per month. And the reason for this is egg quality goes down with age. And egg quality means the ability of an egg when fertilized to produce a genetically normal embryo. And as you can see here on this slide, the percentage of genetically normal embryos varies based on the woman's age. So at age 30, the percentage is about 50%. However, at age 38, it drops to about 30. And by after age 40, it can drop down to 10%. Next slide. And one of the reasons for this is women are born with all of the eggs they will ever have. And they have millions of eggs at birth, and then the number of eggs drops drastically. So by puberty, there's only about 400,000. And then each menstrual cycle, women loses up to 500 eggs. And by menopause, there are no eggs remaining, and that's why the periods stop. Next slide. So in order to maintain healthy eggs, nutrition is very important, and getting enough vitamins and minerals, mainly antioxidants, are excellent at decreasing the effect of free radicals on the egg and maintaining egg quality. So having a healthy diet, such as a Mediterranean diet, eating plant-based foods, folic acid is really important in pregnancy, and that can be found in legumes and dark leafy greens, vitamin B12 and organ meats, and omega-3 fatty acids in salmon. Next slide. Supplements that we recommend for women who are trying to conceive is a prenatal vitamin, and it must contain folic acid, at least 800 micrograms. CoQ10 is another supplement, which is a potent antioxidant, and this is associated with increased egg quality. Vitamin D is recommended. We see improvement in IVF outcomes and decreased miscarriage rates in women who have normal vitamin D levels. So this is a supplement we also recommend. Next slide. For men, there are a few supplements that can be helpful for fertility. One is called Proxseed, which is a multivitamin type supplement that supports male reproductive health. It includes L-carnitine, acetyl L-carnitine, and folic acid. CoQ10 is good for men as well, which can help improve sperm concentration and motility. And then vitamin D. Next slide. It's very important to avoid or minimize toxins when you're trying to get pregnant. Excessive alcohol use will decrease fertility rates significantly. Marijuana use will also impact egg quality, and we see a lot of effects on sperm quality with decreased counts and motility with heavy cannabis use. And tobacco has been associated with reduced AMH and antral follicle counts and reduced IVF success rates. Next slide. When you become a new patient at SCRC, you meet with your physician and we do a thorough medical history review to get to know you. And then we'll do a physical exam and several diagnostic tests. Next slide. One of the most important tests we do is looking at ovarian reserve to get a sense of the number of eggs remaining in the ovaries. And we do this with a few different tests, one of which is an AMH or anti-Müllerian hormone. And this is a marker of the total number of eggs in the ovaries. A normal level is 1 or higher for the AMH. An FSH is a test done on the second day of the menstrual period, and we want the FSH to be less than 10, which is in the normal range. An elevated FSH will predict a poor response to fertility medications. And then ultrasound, when we do an ultrasound, we're looking at the ovaries and we look at the antral follicles or the resting eggs on the ovary, and that gives us a sense of the ovarian reserve, but also how many eggs we would retrieve if we did any type of stimulation for IVF. Next slide. Fertility testing may include a test called a hysterosalpingogram or HSG, and this is a test to look at the fallopian tubes specifically to see if they are open. So here you can see an image of a hysterosalpingogram where the triangular shape in the middle is the uterine cavity. And then the tubes come off of the side. And if they are dilated or blocked, that could be one issue with fertility that would need to be treated. Next slide. Another test that we do frequently is a hysterosonogram. And this is a test where we put a catheter in the uterus and we put fluid inside, and the fluid appears black. And that way we can outline the cavity walls. And here you can see a polyp that is inside the cavity. Large polyps can decrease pregnancy rates, and in this case, we would recommend removal. Next slide. On the male side, we do a semen analysis, and we look for the volume of the sperm, the concentration, and the movement, motility, and morphology is the way that the sperm look. And studies indicate that 25% of infertility could be due to a male factor. And so the semen analysis is a really important test for us to see if there is a problem. Next slide. There are several fertility treatments that we provide. The most basic is something called an intrauterine insemination. And for these cycles, we often give a pill, an oral medication to take for 5 days at the beginning of the cycle, either Clomid or letrozole. And this medication can cause a woman to produce more than 1 egg or ovulate more than 1 egg from the ovary. And we do ultrasounds to look at how those follicles are developing. And when they're the appropriate size, we trigger ovulation with an injection, and then we can perform an insemination the next day. So an insemination, the partner gives a sperm sample, we concentrate that sperm and wash away all of the dead sperm, and we put it in a catheter into the uterus. Next slide, please. The alternative treatment for fertility is in vitro fertilization. And for this treatment, women take injections every day for 10 to 12 days. And these injections are stronger medications that get 10 or more follicles to develop on the ovaries. And while a woman is taking the injections, we do need to see you every few days in the office for blood work and ultrasounds to see how you're responding. About 2 weeks into the process, the follicles would be ready for retrieval, and we would do the egg extraction. This is done under anesthesia, so you don't feel any pain. And we do a vaginal ultrasound with a needle attached, and we aspirate the eggs in the ovary. Next slide. And now Dr. Surrey will talk more specifically about the pregnancy rates associated with these treatments and what that means in women who are over 40.
Thank you, Susan. So I think this is a topic that really drives what we do is, the result. And as you can see, these are our own statistics. And the mean or average age of our patients is about 38. So we don't see a lot of 20-year-olds here at all. And most of the patients we see are over 38, which brings us to our current topic of fertility after 40. So a lot of people come with the idea that they're going to do something and it's easier perhaps to do an insemination. An insemination may give you similar outcomes as things like in vitro do. But that's absolutely not true. And if you look at these little bars, you could see insemination is natural fertility. So it can be good for women who have problems with the cervix being closed, or when the male has a problem with the motility of the sperm that can be improved upon. But an insemination requires that the sperm and the egg fertilize in vivo in the fallopian tube, develop normally, and consist of an embryo that is genetically normal. As Dr. Maxwell told us, fertility declines with age because the genetic content of the embryo declines with age. So when you do an insemination, you don't know anything about that. The in vitro fertilization process allows you to get that kind of information, both structurally from the way that the embryo grows and divides, as well as genetically for the ability that we have to actually perform a karyotype or total chromosomal analysis on each embryo that you produce. So given the fact that many embryos for women over 40 are not going to be normal, if you can find some that are, then we can achieve very good pregnancy rates for these people. Next slide, please. So if we look at, again, our statistics, and ETs are embryo transfers, and if you look at normal fertility, which is insemination statistics being less than 5% per cycle, we've been able to achieve in excess of 50 to 60% per cycle in women over 41, and as over 43. We did 192 embryo transfers last year, and more than half of them had positive pregnancy tests, and almost half had normal deliveries. So this is really an astoundingly good statistic, but it requires technology, and it requires laboratories that are capable of performing this technology in the best way possible. Next. So what happens if this doesn't work? Well, what is called third-party gestation or egg donation works very well. I know it's not something that people would like to start with, but for people who are unable to conceive using their own eggs, if you think about it, an egg donor is a tissue donation. So if you were to have a situation where you're in dialysis because your kidney doesn't work, you have a kidney donor and it's your kidney, and you don't need dialysis because you have a new kidney. if your eggs are not able to work, if you're not producing eggs at all, you can use an egg donor and get the same kinds of pregnancy rates that would have been produced by you 20, 30 years ago. So it's a technology that we should understand and be aware of. Next. Gestational carriers are very different. A carrier is the place where a pregnancy goes. The uterus does not produce the pregnancy. The uterus carries the pregnancy. Age does not in and of itself define the ability of the uterus to carry a pregnancy. There are many women who have undergone menopause where they don't make eggs who can carry a pregnancy successfully. The uterus is an interesting organ that can be prepared for a pregnancy by natural hormone replacement. And it's possible that the uterus can be utilized from a surrogate. So that's a different uterus. So if our patient does not have a uterus, she's had a hysterectomy, she has medical reasons not to be pregnant, she has pulmonary disease or heart disease, she can have a pregnancy with a surrogate. And it works very, very well. Our surrogates are screened very carefully, and they're screened for their abilities to normally carry a pregnancy. And most of the time, they have had successful pregnancies themselves. Next, please. So the egg retrieval process is one that involves stimulating the ovaries. These ultrasounds show us multiple follicles, which, as Dr. Maxwell mentioned, is a benefit to us because more is better in regard to our ability to find eggs and embryos that are going to be normal in order to cause a pregnancy. So it requires stimulation of the ovaries with natural releasing factors that normally come from the pituitary gland that sends signals to the ovaries to make more eggs. While you're taking this, we monitor your response with ultrasounds and hormone levels. And on the day when the eggs are retrieved, that's done by ultrasound, so it's not requiring a general anesthetic or an abdominal surgery. But usually intravenous sedation is sufficient. And people go home within 2 hours after doing this, and may, if they retrieve a lot of eggs, be swollen for a couple of days, but they can go back to their normal activities after. Next. So once we have the egg, if you can look up the slide here, you'll see individual sperm being injected into each egg to cause fertilization and embryo development. And in that manner, we know that fertilization has occurred normally. And we can then watch the embryo develop. And this is something that we are pleased to be able to do in a different monitoring system, in a different environment, which allows us to know that the embryo is developing normally. Next, please. So embryo development occurs over a period of 5 to 6 days and consists of a logarithmic multiplication and division of cells from a fertilized egg at 2 cells, which takes a day, to 4 to 8 cells, takes another 2 days, to 16 cells, to 100 cells. It is at the blastocyst or 100-cell form that embryos will normally be ready to implant. So when people conceive naturally, this is the stage at which that occurs. Next. So we could do genetic testing of embryos that are normal looking. And this is done by taking some of the cells from outside of the embryo, called trophectoderm, as seen here. And these can be checked for their genetic content very accurately, and will give you an entire chromosomal analysis of the embryo on the left side without interfering with its development at all, and without harming the development of the embryo, which the inner cell mass is on the left, away from this. Next. So we have the embryo in a separate place, and we're able to see cell divisions here at 3 days, and then 4 days, and then they form a blastocyst 5 or 6 days that look like this, hopefully. This is a normal looking blastocyst that can be genetically tested and be able to cause a pregnancy. Embryos that do not develop to this stage are not able to cause a normal pregnancy. So this technology that we're able to utilize serves everybody well, from us to the patient, to let us know which embryos you may produce that may cause a normal pregnancy, both structurally and genetically. Next. Cryopreservation is something that's very important with what we do, and it's utilized by what is thought to be freezing, but it's actually something called vitrification, which is like a flash freeze that is very effective at maintaining and preserving human tissue. Our outcomes of fertilization after unfertilized eggs have been cryopreserved are over 75%, half of which develop into blastocysts. Embryos that are cryopreserved survive the process 97% of the time. Eggs 87% of the time. And the implantation rates or pregnancy rates are over 70% of the time. So there have been several thousand babies born with no increase in any complications or malformations from cryopreservation of eggs and embryos. Next, please. Sperm can also be preserved, and it's been preserved historically for many, many years without any issues for its viability. Next, please. So embryo transfers are usually done from a cryopreserved state because cryopreserving the embryo allows us the time necessary to test the embryos both structurally and genetically before transferring them. So it's called a frozen embryo transfer. It's not actually frozen, but it's cryopreserved by vitrification. And pregnancy tests are done in a similar manner 10 days after the embryo is transferred. Next. So again, the success rates in our lab have been remarkably good for women in their 40s if they have had genetically normal embryos transferred. We don't transfer embryos that have not been shown to be genetically normal. Next. So we have a group of partner physicians that are shown here Dr. Danzer and Dr. Alexander are primarily in the Beverly Hills office, and Dr. Maxwell in the Santa Barbara office. And we're very proud to have had over 20,000 births from our services over the last 25 years. So next, we'd be very happy to answer any questions that you might have at this time, or if you'd like to communicate with us by telephone or email, we're happy to entertain any questions, thoughts, or comments that you might have. So, Susan, are you available to answer some questions?
Yeah.
Great.
Let me see here.
So let's see if we have any that have been posted at the moment.
Yeah, so there's a question, what would you recommend to somebody after fresh embryo transfers? I'm not sure what this question is asking, but most of our transfers are frozen embryo transfers, not fresh. And especially in women who are over the age of 40, because we recommend that they do the biopsy of the embryos and the genetic testing, because this can reduce their chance of having a miscarriage from an embryo that's abnormal and increases the chances of having a healthy pregnancy by transferring a embryo that's known to be genetically normal. So if fresh transfers are not working, we would definitely recommend the genetic testing with a frozen embryo transfer. One question here is, what dosage of CoQ10 do you recommend before egg retrieval and after embryo transfer? What do you usually recommend, Dr. Surrey?
400 units a day is more than sufficient. Most pharmacies carry CoQ10 in 200 unit dosages. And it's a great antioxidant. I take it myself. So I'm not having an embryo transfer. So I believe it's a good thing as an antioxidant for your general health as well. So let's see, what are some of the increased risks to either mother or child when undergoing IVF relative to natural pregnancy? Dr. Maxwell?
So there's a few different ways to look at this. I mean, there are small risks of undergoing the IVF procedure. However, less than 1% of patients have any type of complication from that. The risks to the child, there have been large population studies looking at the risks of malformations in children conceived with IVF versus IUI or natural pregnancy. There is a slight increased risk. However, the overall risk of malformations in the population is very low. And it's thought that the increased risk is not necessarily due to the IVF procedure itself, but due to the fact that the parents who are undergoing IVF are older, and there may be an increased risk of genetic issues related to that. So overall, the increased risks are very low from IVF versus natural pregnancy. Next question is, how long do supplements take to have an effect on egg or sperm quality?
You know, they're different questions because we know that spermatogenesis takes at least 90 days. So that if guys are going to take something with the idea of having an effect positively or negatively on sperm quality, it's something that you can have done 3 months ago. You know, I have guys that are reluctant to give a specimen on the day of the egg retrieval because they had a beer the prior night or something, that's not going to really do anything to the specimen. But if they had an issue 90 days ago, it could. For egg quality, it's not at all clear as to how long supplements take to have an effect, but it's thought to be at least a month or more. So, I think we would encourage you to take whatever supplements you are going to take for a minimum of a month beforehand to have any effect whatsoever. And so we like antioxidants for egg quality, but Dr. Maxwell, any other thoughts about that?
No, I would agree. Yeah.
So let's see if we can pull up something else. Let's see. Looking for these other questions. They're not on my.
So
Can you
next
pull up?
one says, if you have eggs frozen in Canada, can I have the embryo development in California? The answer is possible. I usually recommend to patients who have frozen eggs somewhere to consider thawing them at the clinic that they froze their eggs. And then once the embryos are created, you can ship those embryos potentially to our facility. The reason is that eggs are a lot more sensitive to different changes and protocols, and how we do things may be different than how the clinic where those eggs were frozen did things. So that's usually what my recommendation is. I don't know, Dr. Surrey, if you have any thoughts about that.
Yeah, I would agree. Do you have the questions on your
Yes.
site?
Yeah.
Because mine went out. So
Yeah, I can keep going.
See the next one.
Yeah. So the next question is, what is the minimum number of follicles you need to see to do a retrieval for IVF?
Well, everybody's different, and I think it's very important for the evaluation that Dr. Maxwell was mentioning to you about utilizing ultrasound technology as well as hormonal markers such as AMH levels to try to establish realistic expectations before performing anything. So it's only good to know what we're going to expect before we get into this technology. And in that way, we don't have any surprises and we're prepared appropriately for what is a number that we're going to anticipate. So, for example, somebody who has an AMH level of 5 as opposed to somebody who has an AMH level of 0.05, we're going to have very different expectations for. And so the lady with a very low AMH level, she may be in really good shape to have 4 or 5 follicles, and therefore it's a worthwhile procedure for her. The lady who has an AMH level that's much higher would be very disappointed with a small number of follicles. So everybody's different. There's no one answer to the question.
Okay. The next question is, do you have brands of CoQ10 or vitamin D that you recommend?
Not really. I think that every pharmacy is going to be different.
Yeah. Next question is, what is your take for sequential embryo transfer day 3 and day 5? I believe this is asking what's really what's the difference between day 3 and day 5 embryo transfer. At our center, we prefer to do mostly day 5 embryo transfers, and that's because embryos that progress to day 5 are more likely to be healthy, and also they are more developed so they can be safely biopsied for the genetic testing, which is helpful for improving pregnancy rates and reducing miscarriage rates. So occasionally a physician may recommend a day 3 transfer for various reasons, but in order to do the genetic testing on the embryos, we do culture them to day 5.
By the way, day 6 embryos are sometimes necessary and almost sometimes preferable to day 5 embryos. There are embryos that take 6 days to develop, but Dr. Maxwell is alluding to the fact that for what we call blastocyst formation, which is necessary for a pregnancy to occur, takes a minimum of 5 days and frequently 6 days.
Yeah. Next question is, what is your percentage of successful pregnancies with frozen eggs that were inseminated 5 years later? So the success rates from frozen eggs largely depends on the age at which the woman froze her eggs, because egg quality is linked to that age. When we thaw eggs, about 90% survive the thaw and 70% will fertilize normally. And then 50% make it to that day 5 blastocyst stage where they can either be transferred or undergo the biopsy for genetic testing. Let's see. Are there any ovarian rejuvenation treatments available? How would you answer that, Dr. Surrey?
Well, available and effective are very different questions. There are a lot of treatments that have been attempted. We have attempted many of them as well, but we do so in the part of and format of a controlled study, because we don't do anything to human eggs that has not undergone careful scrutiny. And the treatments that have been attempted by and large involve injecting things into eggs and ovaries like PRP and things of that nature, growth hormone, stem cells, and unfortunately none of these treatments have been really effective, other than what we used to do, which was called intracytoplasmic nuclear transfers, where you can take the genetic material from one egg and place it into another egg. The genetic material being the nucleus of the egg, the cytoplasma being the tissue around that. And the cytoplasma does not really contain, if you will, the DNA of the egg. So the effectiveness of that kind of a transfer is based upon where the nucleus comes from. So it's not really something for older patients to attempt to simply establish a younger age for their eggs. Doesn't work.
Another question is longer better as far as taking vitamins? Should you start as early as a year or 6 months? Dr. Surrey, as he stated before, recommended at least a month. if you're trying to get pregnant, sometimes starting a folic acid supplement several months, like 3 months before pregnancy, can be beneficial to make sure you have adequate folic acid levels. What risks to the embryo are there from embryo biopsy?
You know, the embryo itself does not have the inner cell mass disturbed. So the theoretic risks could be in laboratories where they disturb the inner cell mass, you could interfere with the maturation and the progress of embryo development. We don't do that in our lab. So if you're doing IVF and you're doing genetic testing of your embryos, you should inquire as to how they do that, the technologies that they use to do that, because the technology of what we call a trophoblast biopsy will bypass any issue related to disturbing the inner cell mass of the embryo.
Next question is, what is the minimum anti-Müllerian hormone you need to try IVF? So for the anti-Müllerian hormone, this can be influenced by different things. And we often take into consideration multiple different ovarian reserve tests when deciding if a patient will be a candidate for IVF. And it's not necessarily just the anti-Müllerian hormone. Doing a day 2 follicle stimulating hormone is important, and it's a little bit more indicative of if there will be an adequate response to IVF, because in women who have an elevated FSH, that may tell us that they are unlikely to respond to the FSH medications that we give. So it's not necessarily a minimum anti-Müllerian hormone level, but it's related to the overall ovarian reserve testing that we do. Next question, is it more successful to freeze eggs or embryos?
You know, if you think about it, the egg actually probably has more water than any other cell in the human body. And because of that fact, historically, it's been difficult to accurately preserve eggs before the process of vitrification. Either eggs or embryos that are vitrified should be able to be successfully preserved. The difference being is that, as you know, embryos are going to tell us information that an unfertilized egg won't, about its structural normalcy and its genetic normalcy, which will give us much more information about the ability that the egg has to create a pregnancy. So a fertilized egg or an embryo is always going to give you more information and therefore be associated with a better outcome than an unfertilized egg. Now, that being said, if you choose to preserve fertility with unfertilized eggs, that's fine, and you could fertilize them and get that information at any time in the future that you are comfortable with. So you don't have to fertilize your eggs to start with, but in order to answer the question of will this egg cause a normal pregnancy, you need to do that first to answer the question.
Yeah. The next question is, there are many clinics that are hesitant or have strict rules against IVF after 43. Do you have any thoughts or restrictions on that? So in my experience, women over 43, certain women can have success with IVF after 43, but it really depends on their ovarian reserve and how they respond to the IVF stimulation. In general, these women that are successful with IVF have higher egg numbers because fewer eggs are healthy enough to create healthy embryos. So the more eggs we have to work with, the greater the chance is that we will find a healthy embryo that's capable of making a pregnancy. So for me, I don't have a restriction after 43. 44 is okay, 45. After 45, it's most likely that an egg donor would be necessary. Do we have a waiting list for IVF, and approximately how many patients do you have per cycle?
You know, yes, there is a waiting list, but it's a function of a number of different variables, including our laboratory technologies, and we want to only perform IVF when we have a full complement of our laboratory personnel and technologies available, which depends upon the location of the lab as to when that may be. So the waiting list is also a function of the doctor's abilities to monitor and see the patients, because we don't want to accept patients that we don't feel we can give the best individual care to. So we try to create a situation where there is a short waiting list that is based upon our technical availabilities and our physician availabilities. So if there's anybody who is interested, it's a very individual answer, so that we're happy to answer if we can see you.
The next question is regarding someone who's had multiple miscarriages with normal testing, and what sort of recommendations should we have? And often in this case, we discuss IVF, because when we do IVF, we can test the embryos to see if they're genetically healthy. And oftentimes when a woman is having miscarriages recurrent, this is due to spontaneous genetic abnormalities that are occurring, usually due to declines in egg quality with maternal age. So we would discuss with you IVF, if that would be a treatment that would be good for you and our ability to test the embryos genetically. Let's see, if I'm taking a prenatal vitamin that includes vitamin D, do I need to take a separate vitamin D pill? Not necessarily. We do screen vitamin D levels on our patients, and if they are low, we may recommend an additional supplement on top of the prenatal. The next question is, does IVF offer potential benefits in cases where the couple has had successful pregnancies but have experienced recurrent miscarriages in the first trimester? This is another about recurrent miscarriage question. And yes, there are advantages to IVF in the case of recurrent miscarriage, again, because we can test embryos and transfer healthy embryos, which will reduce the chance of having a miscarriage.
One of the leading reasons for human miscarriage has to do with abnormalities of the embryo that causes the pregnancy. So with an analysis of the structure and genetics of the embryo before you conceive, you're going to significantly diminish the chances of a miscarriage. So, Susan, you want to take one more, and then maybe we should allow people to communicate with us privately then?
Yeah. So this last question is, if you're in your 40s with a good AMH and regular menstrual cycles, aside from age, can IVF be considered with my own eggs versus donor eggs? And yes, each person is an individual, and we take a look at all the factors involved, and we do testing that we take into consideration when determining whether or not somebody is a candidate for IVF using their own eggs versus if donor eggs was indicated. So again, it would help to have a consultation with fertility testing to make that determination.
So thank you all for your interest and participation. And we're very happy to communicate with anybody remotely if you'd like, or in person if you'd prefer. So let us know if anybody has any additional questions. And it's been a pleasure to spend some time with you, and we'll look forward to seeing some of you in the future. Dr. Maxwell, any other thoughts?
No, thank you.
All right. Have a good night, everybody. Take care.